Perioperative dental injury is the most common complaint among all medical legal complaints related to anesthesia, and is the cause of 1/3 of lawsuits regarding medical legal anesthesia. While most of the perioperative dental injuries occur during endotracheal intubation, they can also occur when excessive force is used for endotracheal tube or laryngeal mask airway removal when the patient awakens from anesthesia, or in the recovery room as a result of master spasm due to shivering. The incidence of perioperative dental damage has been found to range from 0.02 to 0.07%. However, some studies report a much higher incidence. Take this one study, for example, which reported an incidence of dental damage to be 12.1%. We know that these injuries most commonly occur in people between their 5th and 7th decade of life, and that 86% of the injured teeth were the upper incisors. The anesthesia provider is often immediately aware once a dental injury occurs, and because of the highly sensitive and visible location, patients notice the injuries soon after the procedure. For example, 14% of all dental injuries were reported by the patient, as opposed to the 86% of injuries reported initially by the anesthesia provider. In the perioperative period, the majority of dental injuries occur during tracheal intubation. When a satisfactory view of the glottis is difficult to obtain during laryngoscopy, the patient's maxillary anterior teeth are sometimes used as a fulcrum by the laryngoscope blade. Apart from laryngoscopy, dental damage can be caused by other events like aggressive suctioning in the posterior of the mouth, or a pharyngeal airway placement subjecting anterior teeth to extreme lateral forces, and vigorous biting down upon the endotracheal tube or laryngeal mask airway shaft during emergence from anesthesia. Other events include the forceful removal of an oral airway, endotracheal tube, or LMA, and shivering in the PACU leading to clenching and/or grinding of teeth. The main risk factor of dental trauma associated with laryngoscopy are difficult intubation and poor pre-existing dental status. For example, patients who are difficult to intubate are at 20 times higher risk for dental injuries, and those with pre-existing dental pathology are 5 times more likely to sustain dental injury. Risk factors making teeth more vulnerable to injury can be categorized into patient and iatrogenic factors. These include things like limited mandibular mobility and a narrow thyromental distance, among the many risk factors listed here. The iatrogenic factors include several anesthetic equipment, particularly rigid equipment, if used inappropriately. The following devices are often associated with damage to teeth, and therefore care must be taken when they are used. When using a video laryngoscope, it is particularly important to visualize the laryngoscope blade and the endotracheal tube as they are placed in the oropharynx. A mouth screen technique is suggested by GlideScope. Prevention of damage to teeth can be managed both before and during the procedure by means of thorough evaluation as well as protective measures. The pre-anesthetic dental examination should be conducted by the anesthesia provider, and the findings must be documented in the pre-anesthetic assessment. To avoid any legal complications later on, the anesthesia provider must especially rule out the established dental and anatomical risk factors, such as difficulty in mouth opening and any loose prosthesis. In case the patient has any missing, damaged, or loose teeth, it should be confirmed with the patient and documented accordingly. A notation about the patient's periodontal status and oral hygiene can prove handy. Some anesthesia providers add a dental exam to the pre-anesthesia form. That form may include a diagram of the teeth, with space for anesthesia provider notations regarding potential areas for concern. This not only serves as strong documentation, but provides a good reminder to complete dental exams for each patient. Any history of previous complications during anesthesia must be recorded so as to prevent complications during the administration of general anesthesia. The patient should be informed about the risks of dental trauma, and appropriate warnings must be issued whenever deemed necessary. Documentation of the conversation delineating the risks, benefits, and alternatives to the patient should appear in the medical record. Patients should be routinely examined for dental damage after the intubation and after extubation. Documentation should be placed in the chart stating atraumatic dentition if applicable. In a high-risk situation such as difficult intubation, examination and documentation should also take place in the recovery room. Failure to notice damage and not to know when it occurred will often complicate subsequent management. Use gauze, rolls, or bite blocks on posterior dentition to evenly distribute bite force. And do not use an oropharyngeal airway as a bite block. Several devices are available to minimize dental injury risk during general anesthesia. These devices are typically placed on or around the teeth to protect against damage. In the post-anesthetic recovery area, when the patient is awake and fully oriented, the occurrence of the incident must be discussed with the patient, leaving out no detail and explaining the factors which led to the incident, along with full disclosure of the event to the patient and family. This discussion with the patient, along with any actions or interventions performed in the recovery room, must be documented in the patient's medical records. Additionally, the anesthesia provider must make sure that the patient does not leave the hospital without a clear written treatment plan and arrangements for follow-up with a dentist in the post-operative period. So in summary, conduct a thorough pre-op dental exam. Identify high-risk patients for dental injury. Discuss the possibility of dental injury with the patient preemptively. Document exam and conversation with the patient in the pre-anesthesia assessment and plan. Initiate preventative actions where feasible. Inspect and document teeth condition after intubation. Inspect and document teeth condition after extubation. If high risk, inspect and document teeth condition in PACU. If any injury has occurred, document and discuss with the patient before discharge, with family members present if sedated. Create a follow-up plan, including dental consultation if warranted. Please follow the NAPA Dental Injury Guidelines, as can be found on the NAPA webpage.